Well, welcome. Thank you for the invitation to speak here at the Annual Clinical Assembly of 2021. My name is Sumitra Kandawal, and I'll be speaking about trends in penetrating keratoplasty as well as other corneal transplants. I'm an associate professor of ophthalmology at Baylor College of Medicine in Houston, Texas, as well as the medical director for the Lions Eye Bank of Texas. So keratoplasty, corneal transplants, the world of eye banking is particularly special to me. So a little bit about the history. The first case of a corneal transplant was actually in 1905 by Eduardo Zerm. Now, certainly the techniques and technologies and modifications to surgery have evolved, but it is still the most common tissue transplant in the United States. And it has a very high success rate, and that's due to the fact that the cornea is immune privileged. That means there's not blood vessels in a normal cornea. Instead, the cornea gets its nourishment, it gets its ability to replicate its epithelial cells from the limbal stem cells. And because there's no blood vessels, you don't have to match the cornea by donor and recipient based on ABO compatibility. You don't have to necessarily match it by any other parameters. And patients do very well with corneal transplants with even just eye drops. And some have to be on eye drops forever. And there are some types of transplants where maybe they don't need to be on eye drops forever. The full thickness transplant is called a penetrating keratoplasty, and that is sort of what the standard has always been up until about 15 years ago as far as any treatment for corneal pathology. But when you look at the review from 2005 onwards, you see a decrease in penetrating keratoplasty and a big dip around 2008 to 2009. Let's get into why that is. So when you look at the indications for keratoplasty, there's really four big categories: keratoconus, bullous keratopathy, Fuchs dystrophy, and regrafts. There's other reasons as well: corneal scars, corneal haze, perforations, but we'll really focus on these four major categories. The green indicates the keratoconus, and you can see there that through the years with penetrating keratoplasty, keratoconus has actually increased, but what you see is, and then the red, which is regraft, has sort of stayed relatively stable, but you see a big trend in the blue and the purple, which is bullous keratopathy and Fuchs dystrophy. These are pathology in the back part of the cornea decrease as we now have partial thickness transplants. So let's start with keratoconus and do a little bit of background about keratoconus, the trends and treatments of keratoconus, and where keratoplasty fits in the keratoconus armamentarium for treatment and moving forward. Keratoconus is a progressive corneal ectasia. That means the cornea is thinning, it's steepening, it's weakening in areas, and this tends to actually affect younger patients. Oftentimes, patients may be in their 20s or their 30s when they're diagnosed, but when we look back at patients, they may have actually had this in their teens, if not even younger. And unlike other pathologies, this is something that actually stabilizes once it gets into their 40s and 50s. There are many theories: genetics, weakness of the cornea, eye rubbing, and this can be a bilateral, but also can be very asymmetric. And there are even cases of unilateral keratoconus, although when we look into data that we have published at AJO, that this eye that was quote unquote normal actually had some hints of keratoconus. It's just so asymmetric. Here's some pictures. This is topography showing some of the progression of keratoconus. You see in the top left, this area here, this red, that indicates steepening. So the warmer the color, the steeper. And that shows that this is a cornea that has some inferior steepening, similar to this, for example. But then you can see over the years, it becomes more and more steep. In fact, to this point here, it's almost a crab claw appearance. And so this is progression of corneal ectasia. One could call this keratoconus. Certainly, once it gets a crab claw appearance, it is more peripheral, or in older patients, it is sometimes called pellucid marginal generation. Regardless, the treatment options are very similar. You start with glasses, and the challenge is the glasses prescription can help the patient's vision, but they constantly change their glasses prescription because they have this irregular astigmatism. Glasses can really only correct symmetric regular astigmatism and not irregular astigmatism that is asymmetric, like that inferior steepening. Contact lenses are fantastic, and they've come a long way. Soft contacts, toric contact lenses may not be enough for these patients. Hard contact lenses like RGPs can certainly be a great option. There are some hybrid lens options, and the big game changer is scleral lenses. These can really vault over an ectatic cornea. So here's a cornea that's very, very steep and irregular, and you can imagine a soft contact lens would just rub right on here, and even a RGP may have challenges staying on, but a scleral lens vaults over all of this and doesn't touch that cone because it can be vaulted based on the diameter and customized even in the setting of something like a prose lens, which is a very special type of scleral lens that can be customized. And now there's even more options for scleral lenses, such as something called the iPrint. And so why is this so important, actually? Because in the past, we've just done corneal transplants on these patients. Well, studies have shown that actually if the patient can tolerate a scleral lens, like say a prose lens, they will do better. This is a study that looked at the visual acuity, the percentage of patients 20/40 or better. And what you see is that all the eyes are better in the prose category compared to the keratoplasty. This is best corrected vision with a contact lens. And then you see here the red is stage 4, and you can see that improvement over there. So the patients who say, I don't want to wear a contact lens, I absolutely just want to move forward with the keratoplasty, it's completely understandable, but it's important for them to understand that with a scleral lens, their vision will still be better than if they do a keratoplasty. 1 year later, all the sutures out, best astigmatism possible, but no contact lens, their vision probably will still be better with the prose lens. And then you can see here percentage 20/25 or better, quite a bit. Now you still see here that there's not as many patients who hit that 100%, 99 percentile. That's because there are some limitations, especially with stage 4 cones, as far as visual acuity goes, striae, vault issues, maybe mucus issues under the lens, but still far better than keratoplasty. What are some of the other treatment options? We talked about iPrint. That's a very special type of scleral lens where you actually mold similar to, say, a crown that's done in the dentistry office. And it's very exciting because these can actually vault over eyes that have had other pathology, like maybe a glaucoma tube shunt, maybe a trabeculectomy, perhaps patients who have really horrible ocular surface disease from something like ocular cicatricial pemphigoid, where they get a lot of symblepharon formation. So very exciting technology here that we utilize quite a bit, actually. In fact, our patients are pre-authorized for scleral prose or iPrint. The iPrint is probably about double the price. And then, of course, corneal transplant. And the thing about corneal transplants is that patients with keratoconus do very, very well with it. Here are the 5 layers of the cornea: the epithelium, the Bowman's layer, the stroma, the decimes, and the endothelium. And a penetrating keratoplasty, you go full thickness into the center. You never go all the way to the periphery if you can help it, unless it's a perforation. You leave, the peripheral recipient still there, so you have something to anchor and suture to. But you go full thickness, and these patients, like I said, do very well. This is an example of a penetrating keratoplasty in a patient who actually had a corneal scar. And what you end up having is sometimes we'll put this Floringa ring on. In this case, this patient did not have keratoconus, just had a corneal scar. And we find the center, but once again, leave a peripheral ring. And it's actually my fellow doing the case, so I'm going to help my fellow here. And we go around and cut the recipient cornea that has pathology off in multiple directions, and kind of put a little bit of viscoelastic on, put the donor cornea, which has been cut by us, provided by the IBIC, and then place sutures all the way around. And these patients do well. The transplants can last, average 10, 12 years, better in keratoconus eyes, actually, and maybe less so in eyes that have had inflammation, HSV, keratitis. But still, this is something that if you take a 25-year-old who has keratoconus and you do a penetrating keratoplasty on them, they will need another surgery in their lifetime, and that's something we really educate patients. You can also just do the anterior surface, so maybe the first 3 layers, maybe in the first 4 layers, this partial thickness transplant, where only the anterior cornea is replaced for an eye like, say, a corneal scar or keratoconus. This keeps the endothelial cells intact. That's the back layer of cells that pump fluid. And the young patient with keratoconus has amazing endothelial cells. So there is a little bit of a motivation to keep those cells intact from the actual patient itself. There are kind of two types. One's called ALK, and anterior lamellar keratoplasty, and one's deep anterior lamellar keratoplasty. The challenge with ALK is that there's sometimes a little bit of interface haze because you don't go all the way down to decimes, but it's a little bit easier to do. So here's an example of ALK where you're going through the epithelium, Bowman's, and then stroma, but you're leaving this, and maybe it's actually half of the stroma, maybe it's a little deeper in the stroma. It just depends. But this is actually a good option for people who say are not good candidates for a full thickness transplant, but you're not able to get a deep anterior lamellar keratoplasty on them. Perhaps a patient has very, very severe keratoconus, but has Down syndrome or whatnot. You're not able to get that deep bubble. But the haze can sometimes be an issue for the quality of vision. Here you can see on an anterior segment OCT, here's the epithelium, here's the Bowman's, the stroma of the donor. Here's some residual stroma from the recipient, and there's decimes and endothelium. And so this is a partial thickness transplant, but not going as deep as decimes. DALK is kind of the standard if you can do a transplant on a keratoconus patient. What you do is go in as deep as you can. There are many techniques to do this. Is just a deep bubble technique, able to get that deepness using the bubble to go as deep as decimes, and then very carefully dissecting all the way around. And this is a great, great technique. The challenge is you can perforate, and this is the donor tissue. We take off the endothelium. And you don't really take off the endothelium until you've got the deep bubble, because if you perforate, you can still use that same tissue to do just a regular full thickness transplant. So I oftentimes consent the patients for both, and then if we're able to get the deep bubble, we go forward with the DALK, and if not, then we just convert to PKP, and it works very well. The challenge is that most of the patients that we're doing corneal transplants on have failed scleral lenses, and they're oftentimes stage 4 keratoconus patients who we have more challenges doing deep anterior lamellar keratoplasty, but it's still an option for all. And then you can also utilize the laser at times to get that bubble formation. So here's kind of an example of the femto second laser. There are some pros and cons to doing the laser. Probably the biggest con is just that the patient has to stay still for a full minute under the femto, which is a very, very, very long time. But here you can see a deep bubble, and then using the crescent blade to get as deep, and then similar to last time, watching and suturing, taking off the endothelium. There are complications to any transplant. Here's an example of a patient that has graft rejection with haze. This is a patient who had a suture infiltrate and developed a corneal ulcer from that. And of course, the one that we never want to see for a full thickness corneal transplant is a expulsion, a dehisced PK that results in full expulsion of intraocular contents, and can be very devastating for the eye. So these eyes heal, but they're never quite the same, especially the full thickness transplants. You have to always caution the patient that they need eye protection forever. And we fix a lot of these, and most of them can be salvaged, but sometimes an eye like this, where intraocular contents, including retina, are coming out, there's very, very, very poor prognosis. So what are some of the prevention of keratoconus? Well, avoid eye rubbing is one that has certainly discussed, and then just get older. So getting older. So first of all, with the eye rubbing, it's been a specific type of eye rubbing for keratoconus patients, one that involves sort of using the knuckles, and patients really find that they need this urge to rub their eyes to see better, this urge to feel better. So it's more than just your simple little allergies rubbing the corner of your eye when they're itchy outdoors. And then getting older, as we mentioned before, this is something that occurs in the younger patients. And then once you get to this group, kind of 30 plus years, the numbers of new cases just really diminishes. And then there's some new ways also, not necessarily to prevent, but to stop the progression of cross-linking in patients, and that's corneal cross-linking. The standard corneal cross-linking, basically you remove the surface cells, you add riboflavin, which is vitamin B12, and that's the little benzene rings for those organic chemists out there, and then you shine UV light, which excites the molecules and changes the formation, so it's a linear formation, and then kind of links between two collagen fibrils, and then causes more strengthening to that effect. And this has been shown in many studies to stop the progression of keratoconus. This is some in vitro studies showing that with the riboflavin UV light, there's more strength to the cornea. And this just kind of talks about the change in the K value. This patient was kind of getting worse, and then they sort of stabilized. This is some examples of topography where the patient Once again, the goal is stabilization, but you can actually get some improvement. Pre-cross-linking, post-cross-linking was 53.16, 59, and then flattened to 52 and 57. So these are usually very mild improvements, but excellent considering they were progressing before. Here's an example of pre-cross-linking and post, and this is a nice difference map. So the blue shows they flattened inferiorly, which is fantastic. This person also flattened quite a bit inferiorly. I always tell patients, this is something that's supposed to stop the progression and hopefully flatten the cornea. You may not notice any improvement in vision per se, but I'm going to be very excited because the pictures will be getting better when you are actually getting worse. And that the flattening effect actually goes beyond even 6 months to a year and can actually go up to 3 years, 5 years, 10 years, 15 years, but you get your most flattening effect with cross-linking over the first year to 2 years. Additional studies showing that the vision improves a little bit. Maybe you get improvement of a line of vision, but certainly it's not something where that's the expectation. And there are some ways that we can, sort of tweak the protocols, but the biggest limiting factor for patients for cross-linking is the fact that they really need to have adequate pachymetry for an epithelium off protocol. You remove the surface cells, and you need to be able to have enough cornea to keep the intraocular content safe from the UV light. So that has always been sort of the limiting step. Fortunately, we have some ways to swell the cornea during treatment to get it up to that 400 microns. There are some concerns that maybe it's not effective if they're very thin corneas. But if you think about the other option, which is a corneal transplant, this is pretty good. So in summary, cornea cross-linking halts progression, flattens the cornea. Thus, alternate protocols are out there that show promise. Corneal thickness is a limiting factor, so that's why it's earlier. In fact, I'll have patients come to see me who want corneal cross-linking in their bad eye, but actually their bad eye is very thin and not a candidate. So we actually start talking about corneal cross-linking in their eye that they thought was their good eye, which it is. And then we talk about transplant in the eye that's too advanced. And we'll see what future holds for this. There are going to be some great options for alternate treatments, some expansion of FDA protocols. But really the goal is it prevents need for transplants. So we may see this keratoconus green line actually go down through the years. Next, we talk about bullous keratopathy and Fuchs, and really anything that affects the posterior part of the cornea, the endothelium. We see a trend, the blue being full thickness transplants decreasing and the green being endothelial transplants. These are all requests from the eye bank increasing. The different types of names. This is like posterior lamellar keratoplasty is sort of what it's called. It can also be called endothelial keratoplasty. And essentially, you're just replacing the back layer of cells. Definitely endothelium, maybe descemes, maybe a little bit of stroma too. But it keeps the anterior structure of the cornea intact, so you won't have that full thickness vulnerability. And it's a much quicker recovery and smaller wound. There's DSEC, endothelial keratoplasty, DMEC, descemes membrane keratoplasty, kind of remember by the S and the M. And there's various other options as well that we can briefly review. And basically with DSEC, you're replacing the endothelium, the descemes, and probably a little bit of stroma, maybe 10 microns, 20 microns, 50 microns of stroma. The thicker the graft, the easier it is to insert, but maybe the vision may not be quite as good, but we're talking about a few letters or maybe even a line of vision. And then DMEC has excellent outcomes, and basically you're just replacing endothelium and descemes. So here's an example of an anterior-segment OCT of a DSEC. All the anterior structures, the epithelium, the Bowmans, and the stroma are the patients. And then you can see this DSEC tissue is fantastic. There's a little bit of stroma, but really it looks really great. There's the endothelium. The edges here, you'll always be able to tell the difference between how thick it was. You can see here, this is a little thicker on this side compared to that. And that may affect visual acuity, but these patients oftentimes are very happy with the vision. Here's a video, or basically stripping descemes. You got to take out the old cells. Some patients don't have any endothelial cells, but it's always worth stripping just to see, and then bringing everything forward here. And there's so many different techniques. This is actually more of an older technique. There are better instruments now that can help really bring some of that endothelium off, and it's a little bit of give. And then here we're going to kind of pull it out and just see how pretty it looks on the cornea, knowing that you took all of the descemes out. And then here is a punch, and we're going to take that. And usually this is back in the day when we were pre-marking the DSEC tissue, and this is an old technique where we just stick it in with a needle. Now there's so many great techniques, Endocerter or boost and glide, slide and glide, and so lots of different options since this type of video for inserting the graft. And you can see here, you can tell there's definitely a DSEC graft. You can see the edge all the way around. This is the gas or air bubble that we utilize afterwards. And you can see the edge right here. But this has been very successful, very good for eyes that are not DMEC candidates because they may have tube shunts and stuff, and we'll show you why that's important. But there are some downsides to it. Probably the biggest thing I always tell patients is that the graft may detach. Here's an example where the graft is detached on week 1. In which case you need to put additional air on day 1 or week 1 or week 2 in order to make this kind of squeegee together, because this graft only sticks and velcros onto the recipient if something's pushing on and the pressure is high enough. This is DMEC, so unlike that where you saw that demarcation, here is a DMEC graft, and you can see that you can barely tell. This is all recipient except for this one little layer here because you're only replacing the back layer of cells. This is a video showing that how delicate that tissue is. You punch the tissue, and now we even have some preloaded options. You very delicately lift that tissue, very different than that other tissue we can just slip in with a needle. This tissue behaves differently. It sort of has to be loaded. It curls into a little scroll, as we like to call it. And that scroll behaves so differently. All of ophthalmology, we're taught to form the chamber, and in this situation, you actually want to shallow the chamber to get it to unfold, and then you put a gas bubble in afterwards. But you can tell in these pictures, you can barely tell there has been any surgery, actually. And that's the thing that's really interesting about DMEC. The cells, maybe because there's no scaffold effect, they migrate, and oftentimes, a year later, 6 months later, our med students, our referring doctors will be like, did they even have surgery? And the answer is yes, they had surgery. But you can't really tell. You can really tell with the DSEC, and you can't really tell with the DMEC. And when you do an OCT, once again, you can see the difference here versus DMEC, where it looks almost like that. So, there's also some ways that one can, there's always some pros and cons. DMEC is a little bit more technically challenging. You have to unscroll it. This is an example of a case where first of all, the view is very bad. We had there's kind of this debate, if the view's not good, maybe you should just do a DSEC, the thicker tissue. But in this case, we were motivated to do a DMEC, and it's been a lot of time spending trying to untap. And then we finally untapped it, and the S-stamp is backwards. So now we got to put some fluid in, form the chamber, get it to dance again for us by now. And then right when we're putting in the gas, the patient moves. To our credit, it's been there for a while. And now we have heme, we have blood in the anterior chamber, which is never good. But actually, after all of that, and after being in the middle of the OR saying, oh my goodness, why am I here? Why didn't I do a DSEC? The reality is this patient did super well, actually, super duper well. We had done cataract surgery right before, so we probably worsened the cornea a little bit. But I always see my patients, a lot of them come from far away. I always see them a few days before I decide to do a DMEC because just to make sure that their cornea has not decompensated more if they're kind of on that fringe borderline gray zone where I'm not sure DMEC versus DSEC. It's always important to maybe check on them just to make sure their cornea is not worse. But patients do very well, and if you can do a DMEC, it's always great. Red is DMEC, blue is DSEC. The lower on the logMAR, the better vision, and you can see tremendous improvement in vision in the DMEC versus the DSEC at the 1 month, 3 months, 6 months. But this is the key. At 12 months, you still get better vision. And I mean, when we talk about patients about short-term goals, that's fine. Patients oftentimes are patient enough to be okay with the different procedures if the outcome is still the same. But I think the real key is that 12-month mark is better. And also, we have to also keep in mind that a lot of times now we are doing DSEC in eyes that are a little tougher. Maybe the view is tougher, maybe they're more advanced corneal edema, maybe they have other problems with their eye. And so we'll keep that in mind as well. So DMEC is safe and effective. This came out of the AAO. Superior to DSEC in regards to visual recovery, visual outcomes, rejection rate, refractive error, endothelial cell loss. And, the key is, air injection and, how to manage them and the actual surgical learning curve. And once you have gotten over that learning curve, the rebubble rate and repeat keratoplasty is actually similar per their review of the literature. So in summary, we do PKP DULC for full thickness pathology, keratoconus, corneal scars, or if they're unable to have an endothelial keratoplasty, you have to lay flat after EK. Some patients can't do that. Some patients have had so much surgery that it's just better to do a PKP. Maybe they don't have an anterior chamber. There's iris coming to the cornea everywhere, and you just don't have room to do a DSEC or a DMEC. DSEC is best in my hands for tubes and trabs. I put post-PPV on here for starters, but honestly, I consider a DMEC in some patients who are post-vitrectomy, but in general, it's much tougher surgery. Aphakia, I do not do DMEC in aphakia because that scroll can go right back to the posterior chamber. So can the DSEC tissue, but it's easier to control that. And then iris pathology, better to just do the DSEC. And then DMEC is our preferred EK, though, in normal eyes, eyes with Fuchs, eyes with PBK without some of these risk factors. So we see this trend in increased endothelial keratoplasty. What's next? Well, maybe you won't have to do any of this stuff. So let's talk about what you do to fix a cornea, and you don't need to do a transplant. So desmetarexis, this is for EK. Instead of doing removal of Descemet's membrane and inserting a graft, you just remove the central 4 millimeters. Perhaps it's a younger patient who has not had cataract surgery and you don't want to make their cataract worse. Perhaps it's somebody that has fairly okay cornea, except the center 4 to 5 millimeters has tons of guttae. And, in this study, they did just the desmetarexis. This is Catherine Colby's group. And at 1 month, 4 of the 13 patients had cleared. And at 6 months, 10 of 13 patients had cleared. And then those 3 remaining eyes ended up having EK. This is excellent. You don't have to worry about tissue. You don't have to pay for tissue. You don't have to worry about gas bubble positioning. The challenge, though, is that's a long time. 6 months of very blurry vision. And you still had 3 patients that had EK. Maybe, though, you can do something else to help that increase your odds. So Rho kinase inhibitor is a serine threonine kinase. It inhibits inhibition, can enhance cell proliferation, inhibition of Rho kinase, promotes cell adhesion, and suppress apoptosis. And there's 2 particular ones that have been studied to enhance the rate of wound healing and the recovery of corneal transparency. So this is just an eye drop in a patient with endothelial dysfunction. Pre-treatment, this is what they look like. And post-treatment, they still have a little bit. They haven't completely rescued themselves, but their endothelial cells are certainly pumping better. And this is different than like Muro 128 or salt drops, because you're not just treating the symptoms, you're actually having an improvement in endothelial cell function. And in the case like this, you can do Descemet stripping, remove these 4 millimeters here, and then add the ROCK kinase inhibitors. So in this study, they did 12 eyes, and they did the Descemet stripping, and they also used a ROCK inhibitor. 3 eyes required salvage treatment, and 2 cleared, but 1 ended up needing a transplant. And basically, they went ahead and just did Descemet stripping, but if the cornea wasn't healing, they went ahead and used the ROCK kinase inhibitors as kind of a rescue. So this kind of improves the odds. But maybe you don't even have to do all that. Maybe what we can do is improve our odds even more by doing injection of cultured cells with the Rho kinase inhibitor with a Descemet's removal. So this is a series of 11 patients who had just injection of endothelial cells and ROCK inhibitor injected. They had to be in the prone position for 3 hours after surgery. 3 hours, that's quite a bit. And prone, not supine, which is kind of the opposite of what you think. But they actually had excellent outcomes. At 4 weeks, we see an improvement. Not everybody, though, but we do see an improvement. And here's quite a bit of improvement actually at the 3-month mark, and then you have patients before cell injection and then after. But this is very early. This was published in New England Journal of Medicine. Studies have continued across in Japan and other Asian countries, and we still need more data. We need an actual FDA trial here before this can be prime time here. And I think we're still a few years out, but it's still going to be very exciting. So with DMEC, which is our preferred EK, perhaps we don't even have to worry about that. But there's still probably going to be a role for these other corneal transplants for sure. And I bet there'll be some patients that don't quite do as well with just endothelial cell injection and may end up needing a DSEC or a DMEC. So that's just disruptive stuff. That's always exciting to look forward to. So the options for treatment to delay or prevent need for keratoplasty, and for keratoconus, for example, that's cross-linking on scleral lenses. We also see an increase in lamellar transplants, especially endothelial keratoplasty. It's going to be very exciting to see where this goes in the future, and where things like injection of endothelial cells takes us. And then future treatment for both anterior and posterior corneal pathology may further decrease the need for transplants in the future. Thank you.